Good.
So, hello. Hi, Patricia, and hello, everybody. I'm Yuval Alon. I'm an ISTDP therapist from Israel. And today I will be talking with Dr. Patricia Coughlin. She's a clinical psychologist, and she has over 40 years experience and over 30 years experience in teaching ISTDP, treating ISTDP in the United States and all over the world. And the goal of this talk is to try and highlight factors that are important for the psychotherapy process. Hopefully that it will be helpful for as many people worldwide. So thank you so much, Patricia, for agreeing to talk to me today.
Sure, thanks for having me.
And if we can start, you have written a few books, and there is also a new book that is coming next month, right?
Number 4.
Number 4. So I was thinking as a start, and also maybe as a guide to our talk, that you can take us, as a conversation, of course, not just, but you can take us at milestones in your journey, maybe through your books, and what led you, to send the message, because there must have been something there, you wanted to share with others, and what is the development that you had, in your very rich career. So can you take us? Can we start from that?
From the first one.
Yeah, we can start. We can start also from the new one. Whatever, it doesn't have to be.
We can go. Yeah,
we don't have to go to the past.
No, but it's okay. It makes sense. So I was, I would say, a relatively traditional psychodynamic psychotherapist. I got fabulous training, and was working, seeing patients, usually 2, sometimes even 3 times a week, for long-term treatment. And sometimes it was really effective, right, and deeply gratifying for both of us. And other times we didn't get anywhere, and I definitely had the experience of my interventions just bouncing off the wall. And yet I had no tools to deal with that. We just had interpretation and so on. So after about 8 years of this, I was getting a bit demoralized, frustrated. And it just so happened that my family, we moved to Toronto, to Canada. And I got a flyer in the mail saying that this guy Davenlou was coming to town and he was going to do a workshop. And I remembered reading about him. And I swear to God, I also saw a video of him in graduate school. I don't know how that happened, because he never lets them out of his sight, but it was some bootleg thing. And so I remember being impressed with him. And so I went, and for 16 hours, sat in the dark watching the German architect and the machine gun woman. And, I was just knocked out. And I thought, okay, here's a method. Here are effective interventions where I could see the unconscious just open up in the most unmistakable way. And I thought, this is what I've got to do. And so, I started training, and luckily was, chosen by him to come to Montreal and train. So it was at that point, prior to that, I wrote, some papers and things, but I really didn't feel like I had anything particularly, new or important to say. And yet once I got exposed to Davenlou, I started to feel like, hey, I want to share this. I have some things to say here. So first I just started writing articles, right? 91, 92, 93 in the short-term journal. And it turns out that Wiley publishes that journal, right? So little did I know that there was an editor who was reading those things. And it just so happened I was going to be presenting a workshop at the American Psychological Association's annual convention in Boston, 93 or something. And I guess editors go to these things, right? They figure, well, this is where the experts, the profession does the vetting, right? So they're only going to invite people who are, offering something.
Yeah.
And so I get a phone call from Kelly Franklin, who was an editor at Wiley. And she said, I see you're presenting in Toronto. We're going to be there. I'd love to meet you and let's talk about you writing a book. And I'm like, wow, okay, great. I mean, like this never happens, Yuval, right? I mean, publishers don't come to you, right? I mean, this is just, I'm like, wow, okay, yeah, sure, I'd love to. I mean, I had no clue how to do this, right? And so we met for lunch and literally, on the napkin, she started to, write out the formula. You have to write a proposal. And then she was going to pitch it, to the editorial team. And that was in August the APA. And by October, I had a contract.
Amazing.
And yeah, really. So it was meant to be, right? But that was, so I found that again, once I discovered ISTDP, somehow I started to have a voice, right? And I wanted to share and write, and it came relatively easily. I had these amazing cases, that I thought illustrated the really important points. And so in those days, of course, this was really before internet. This was, it was published in 96. And so it's like, you have to submit paper, you submit your book, they do the copy editing. And then it was like 6 months between when I finished it and last saw it, and then suddenly the book arrives in my office. I'll never forget it. And so I opened it up, started reading it, and thought, oh, this is good. Who wrote this? I mean, so, and then from that, I mean, I never dreamed, but the publication of that book, obviously, it started to touch people, and I started to get requests from Europe and Australia and all over to come teach. And once again, like I had never thought, well, what do I have to say, right? But somehow this method and the process, I just felt really passionate about and inspired to share. So yeah, so that was the first book, and it's still in print.
Yeah, it's the blue one, right? It's the blue one.
It's blue, the paperback. Yes.
Yeah. The intensive short-term dynamic psychotherapy.
Theory and technique. Yes. So that's what it was. Right. Because Davenlow, there literally wasn't a single book that had been written that sort of laid the theoretical foundation and then outlined the procedure, right, from beginning to end.
Right.
His books are just compilations of his articles. So it was a little bit piecemeal. You'd have to put it together, yourself. So, and then it's been translated into, Korean and Portuguese, Polish. I just never dreamed that this would happen. But obviously there's a desire, right?
Yeah.
And a need in the field, right, for more effective dynamic psychotherapy. So
that's amazing. So your passion. So it was a calling, like you
totally.
got the call and you went for it, and your heart was there, and you are all there. Can I ask you about when you started learning? Because you said, you were really passionate, but still, it's a massive shift from the traditional, right? So how was it for you? How did you embrace it?
I've said this before. It was like a duck to water. I mean, I was so happy, right, to have license, right, to say what I was seeing, right? Because before I would see, like I remember one patient where I mean, week by week, she came and was getting bigger and bigger. I mean, she was just gaining weight. And, of course, I'm noticing this, but how do you say it? I mean, you can't say that. It's, so for me to finally see this.
Free at last.
Exactly. And I mean, I don't know if you've seen it, but like my first trial therapy ever was the cold-blooded businessman. Not an easy guy. I mean, he had been rejected by the Center for Stress and Anxiety Disorders, which was run by David Barlow, okay, the big CBT guy. Well, they evaluate people up, down, and sideways before they're going to let them in a clinical trial. So they don't want anybody complicated, and they don't want anybody with character disorders. Well, hello. I mean, that's who we're seeing every day. Yeah. So he was rejected by them, and they sent him to me. And he was a tough nut, but we got there, right? So even from that very first trial therapy, I mean, it worked. I was able to get through the central dynamic sequence. Yeah. I had my little cheat sheet, so I'd remind myself before the person would come in, okay, inquiry with specificity, defense work, And so actually,
yeah,
my first cases were really effective. I don't know if it was beginner's luck or, but again, we know that this combination of deep domain-specific knowledge, right, which I had, right, and enthusiasm and belief in your method, like this combination
the presence, like your presence in the like closeness, emotional closeness.
Right. And so it was really effective. So for me, it was so reinforcing, right, because I was quite successful from the start. And then just an upward spiral, right? Because what's more empowering, right, than being successful in your interventions? And, a person would leave and after a trial therapy, and I'd be like, wow, so I think that's the other thing. My curiosity is unabated. I really am curious to understand people deeply. I don't feel like, oh, I already know this,
Yeah.
Because everybody, we're alike, but we're also different. And so to me, it's endlessly fascinating and so gratifying to see people free themselves from suffering and then have access, to their own energy, their own gifts, and then to see what they create in the world. I mean, this is the other huge gift. Really was from Malin, who then, basically talked to Davenlo about it, which was doing follow-up interviews. And so I get 1, 5, 10, I even have 30-year follow-up on some people. And so to see what they have been able to do with their lives and that circle of, expanding circle of impact they have, on their family, and friends and work life, it's incredibly gratifying. Yeah.
It's amazing. And from someone that is learning from you, I can say that you can really feel your curiosity, and you're really, so specific about the process, about not letting things slide away, and being on top of things in a curious way, not in a rigid way, like in a curious way and in an open way.
Yeah.
And I think that is really is an important factor, to be present in a curious way. That can be like really help, I think, a lot of people not to be over on the technical.
Exactly. Because, there's tons of research that therapists who are rigid, authoritarian, and who stick to their method, no matter what, actually get very poor results. And so it's that balance between having a method, right, that you're knowledgeable and passionate about, but being quite flexible in how and when and what, you're going to intervene based again, on the patient's response to intervention. And so let me just say that while I was pretty successful from the start, and that was, of course, empowering, I also had and continue to have failures. And
Yes.
this is very important, right? So as I was writing my most recent book, I talk both at the beginning and the end of the book about some colossal failures and what we learn from that, right? So it's real, we're all going to fail. And the more, in a sense, ambitious you are, right, and you're going to go for it, sometimes you're going to fall on your face. And don't berate yourself and then go into a funk. It's like, okay, what do we need to learn from that, right? And so in the first one I talk about, I was in training with Davilo, and so he used to talk, of course, about being effective and efficient, right? Everything had to be as fast as possible. So I would say to people, yes, we have to be as efficient as possible. Let's go, go, go. And so this one woman who had come to me for anxiety and depression, but she was extremely isolated, withdrawn, very timid. And she really had, a character structure that kind of set her up for this. But I was so eager, right, to get these results. And, the initial interventions were very effective in helping her with anxiety and depression. So she came and said, hey, I'm really feeling better. I'm not depressed. And so I'm like, okay, so then I guess it's time to end. And, like after 10 sessions or something. And of course, because she was so meek and compliant, she said, oh, yeah, okay. And I thought everything was just fine and dandy. And then when I called her a year later for follow-up, she said, oh, I couldn't possibly come back to see you. I said, what? What do you mean? And she said, oh, I was devastated. I mean, when you said, oh, you're better now, let's just stop. She's like, I actually thought you cared about me. I mean, clearly you don't. I was like, oh my God, and I said, oh, I'm so sorry. I said, I wish you had said something. Please come in. I won't charge you. Let's have a session. She's like, no way, I couldn't. And I was like devastated, right? So I really had to think, wow, what did I miss, right, in my zeal, right, to be effective and to get these, symptoms out of the way? I really missed the person sitting in front of me. So I don't think I repeated that mistake again, And then the other one really, and there was sort of a group of people that I realized I was not effective with in a particular framework. So prior to the pandemic, right, when we saw everybody in person, if somebody from a distance wanted to come see me, we would do what we call block therapy. So people would fly in from other states, other countries, and I would do like 4 hours a day, 2 in the morning, 2 in the afternoon for 3 days. And what I found was that there was a specific category of patients. They all happened to be male, in their 40s, wildly successful, multi-millionaires, right? Tech guys, whatever, right? Sold companies for $100 million. And, so they were good looking, smart, successful, incredibly narcissistic. And in every case, we're really being referred by somebody else, right? The people they were working with or the wife or whatever. And well, actually, all of them, if they had a complaint, it was that they couldn't seem to sustain a relationship. That, of course, women were throwing themselves at their feet. But, and they might have a fling for a month or two, but they got tired of everybody. And, so this kind of character pathology, which is so supported in our culture, right? These guys get away with murder. They have very little internal motivation. And in a way, what I realized is them wanting to come for a block where they could be, again, sort of wham, bam, thank you, ma'am, like come in and out, not have to get involved, not develop a relationship. I realized, you know what, this is counter therapeutic. Like, I'm not, it's not possible to treat that kind of character pathology in 3 days. Okay. And so these are important things to recognize. When is this method not really appropriate and something else is required? Or also for each of us, we all have our strengths and weaknesses, right? So there might be certain kinds of patients you're really good with, and others you find over time, you know what? I'm just not good at that. And so
honest.
You can try, but refer them to somebody else, So I think it's important to have that.
So regarding those patients, so you about yourself, you said so I just can't do it in this format, like it's not therapeutic, it's not for me, I can't do it in this format.
It's part of their pathology, right? That's how they want to do it.
This also speaks again about really being specific and really, not just taking in, a patient because a patient is coming. Really think about, and also learn as you go, right?
Yeah. So this is the other thing that was such a gift, is really learning how to do a very thorough evaluation, right? So like in the old days, somebody would call and say, can I come? Like, you almost assume they're your patient from the minute they, there was no real evaluation. And we are both here, right, to assess what's the nature of the difficulty, what's the underlying source, is this method, and also this match between you and me. Optimal.
It's like from the therapist stance, and I also see it a lot. That it's like this is already a relationship. Like there is no will to the therapist at all.
Exactly. Like, as long as they're coming, as long as they're paying, right?
But and we will say this is starting now. But actually, it's not really there from the part of the therapist.
Right. And this is so important because research clearly shows that patients' history and their DSM diagnosis, neither one is prognostic at all. So the only thing that's going to tell you whether this person can respond to you and your method now is to test it out in that trial therapy and to track their response to intervention. And, you can be surprised, right? People who look like they're super well put together, you put them under pressure, they totally fall apart. And, and somebody else who has the most horrendous abuse history, they dissociate, have migraines, but they're incredibly responsive, and motivated and resilient. So you can't tell until you see somebody.
Right.
And having that time, the 3 or 4 hours to really evaluate the person in a systematic way is invaluable, right? So you don't wait 6 months and then realize, oh, this really isn't a good fit. Hopefully you're going to know that.
And a lot of the time, so when I, also talk to therapists about the therapeutic alliance. So the idea is about the therapeutic alliance. So, we need to wait. It is too early. All of these assumptions that are really are a stance of in psychotherapy still.
Right.
Like we can't test something, or check. We can check, we can talk, we
Right.
like.
Look, our field has greatly contributed to this culture of fragility, treating everybody with kid gloves, like assuming that people are fragile. They couldn't possibly tolerate, you speaking to them directly and saying what's so, or whatever. I mean, it's really, so that's the other thing is, we've been intervening in a way that kind of supports people at their lowest level of functioning, rather than really challenging them and challenging ourselves to operate at our highest level of capacity. So I remember being at this psychoanalytic conference where, a rather well-known person was telling this story, because of course they never show the work, they just tell you about it. And he was actually proud of the fact that this middle-aged man had come to see him and had been coming several times a week for 2 years.
Yeah, I know.
And
I know that.
Finally, you know it? Where
no, I know the kind.
No.
Like,
And so then he says, and then because we had created such a, he was able to tell me why he had come. That his son had died. It's like, what? To me, that was malpractice. And why and how you could begin a therapy without being clear and agreeing. Why are we here? What are the problems that you're having that you want my help with? I mean, I think it is outrageous, actually. And so, again, when, we tend to use Borden's definition, right, of a therapeutic alliance. He operationalized that, right, and it's agreement about the problem and the goal, and then the task. And the task is the most rarely agreed upon.
Right.
In fact, in most cases, therapist and patient have different ideas.
The will is getting there, like, okay, so are you willing? Like you're telling a lot, like when the patient see the defense. Right. So are you willing to really take a look so we can do it? Yeah.
Right. But they have to have already been helped to see that their depression, for example, right? When you're saying, well, when did that happen? And what was going on there? And, oh, you say it's happened before, right? Is there a theme? What is the trigger, right? And then you'll see, right, that it's they get depressed every time there's a major conflict with someone, right? So then you would begin to test out your hypothesis, right, that in this case, depression is a result of anger turned inward, right? So you test that out. What kinds of feelings do you have towards your boss? Oh, I guess it's me, right? So you can show them, look at that, right? So you don't tell me actually how you feel toward him, right? You turn it back on you. You attack you. You start to cry. Do you see that? That sounds like a recipe for depression, isn't it? So they first have to see that, right? That the ways they're avoiding their feelings are creating their problems. And then the task would be, so you'd say, okay, so since all these ways you're avoiding and repressing are causing the problem, does it make sense to you that we're going to help you face those and experience them directly?
And I think this is also highlight this. So patients really can't do anything about anything if they can't see it. Like, in day-to-day life, if we don't see something, we can't do anything about it. So.
Right. I mean, that's the definition, right, of a neurotic. They're blind, so they continue to fall into the same ditch.
Or it's our job to show them, to help them see, and then to allow them, this is your choice. So we can do it together. This is your choice. We are not there to do it for them, not stepping in the shoes of any parental or attachment figure. That's right. So, but patients have to see. This is maybe I also think this is our obligation.
Yes.
This is our obligation for them to see, because so far they are, say blind to it. So defenses just operates and dictates their lives.
Yeah, and then that we really honor their choice, right? Rather than forcing our agenda, right? It's not up to me to barrel through somebody's defenses. I can just point them out, invite them.
Yeah. Well, this is making it complex because we do, as you say, a lot of the time, we do have a stance, but we need to pay attention not to,
Exactly.
Yeah.
Right. So in that sense, I mean, the person can say, no, I don't want to do it.
Yeah.
And you say, that's fine. But then what are we doing here? So we don't form a collusive alliance, right? Which I think a lot of therapists do, right? Where they continue to see people and take their money when nothing therapeutic is going on.
Yeah.
Right? And they're just complaining about other people or whatever, right? So we really would say, of course, that's your prerogative, right? But if we can't agree on what we're doing here, then we shouldn't meet, And that has to be honest, not some ploy, right?
Yeah.
To get them to stick in there. Yeah. Yeah.
So if we go back to your journey, so there was so we went through a couple of from your first book, your passion, and then you were discovered actually.
Right. Right.
And then you wrote another book with David Mellon, right? Life Transformed. So
that's right.
Can you take us through?
Yeah, that was not my idea. That was David's idea. So
discovered number 2 again.
Yeah, I met him in the late 90s. It was a conference in New York City that I believe was organized by Michael Alpert. And Lee McCullough, who really is the one who had reached out to Mellon. Mellon was retired. He had, again, he was treated poorly by Davenlow, like a lot of people, marginalized. He just kind of gave up and he thought, I'll just live my life in England. And really, it was Lee McCullough who sought him out and brought him back. And so he started to join with us. And so we met, and actually I showed the case of the cold-blooded businessman. And he pounded on the table, he was the discussant. And he said, this is evidence, right, of the power of dynamic psychotherapy. And he went through it, this is where he started, this is where he ended up because of this intervention and so on. He really was a scientist. So he came up to me after that and he said something like, you have to write another book. And I said, you know what, at that point in my life, raising kids, doing all, I thought, I don't have the time and energy to do this by myself. I said, but if you'll do it with me, I'll do it. So he said, okay. So and it's so interesting because once I said that and once I had a partner, I just started writing. I wrote 80% of it, right? But to have somebody to say,
it's in your mind,
yeah. And so that was
working together.
Yeah, it was really great. Yeah.
What was about it? What was the focus there? What was both of you trying to say in that,
Yeah, good question. So in the first book, I really was talking about theory and technique.
Right.
And in this case, what was really brought to the fore was research, right? And to me, those are the 3 prongs, in my little triangle of competence, right? If you want to be highly competent, you really have to be very conversant in all 3, and they all inform each other. And so David had always been passionate about doing follow-up, and he did not put much stock in these paper and pencil tests because that's someone's conscious reporting, and there can be all kinds of conscious bias. And so he really wanted something more dynamic. And so way back in the day, in the Tavistock, they did these follow-up interviews that were very specific to the patient, right? You came with depression, you were suicidal, right? Tell me how you're doing now. And it would be very specific. So they would have already, identified what that person's trigger was. Let's say it was loss. So you would want to assess, so have there been any losses, right? You'd want to know
specifically
that, well, yes, in fact, right? My father died and my sister was killed. And I was able, right? They not only did not fall into depression, right? But were able to deal with it in a constructive way. So it was very systematic, and he would want specific examples. So he wouldn't accept if someone says, yeah, my marriage is great now. Well, what do you mean great? In what way? Right? And how about your sexual relationship? And, he would ask for specific things. And so that's what he wanted to do with my cases. So we took 6 or 7, and he and then had another clinician also just look at the trial therapy. And then they predicted, this was really interesting, what they thought would have to happen for the person to resolve their conflict. So I'm thinking of The Man Divided, in which, he had major trouble with women, right? It came up straight away in the transference with me. He was on his second marriage, and both marriages he was unfaithful. And this was related to, a lot of unresolved mixed feelings toward his mother, who, he considered ridiculous, a ridiculous woman. And so, of course, both of the assessors felt that we would have to go into great depth around feelings toward his mother. And interestingly, this was an extremely successful case. I don't think we ever got into the feelings toward the mother, toward me, toward the wife, toward his brothers, toward the father. I mean, and yet at follow-up, like I think it was 10-year follow-up, he had gotten much closer to his mother and had been with her at her deathbed, and it had been very profound. And so this sort of underscores the findings by Alexander and French way back when they found you do not have to go through every single person that you have mixed feelings toward. If you go in great depth, even with one, so let's just say you're on one place on the triangle of person, right? But you do lots of restructuring, you get a deep breakthrough, the person sees their pattern, how they've been contributing to the problem, and sometimes that gets resolved, and then it is, in fact, naturally generalized to other cases. So that's just an example, but basically it was to try to have a sort of more scientific and cumulative N of 1 studies.
And also, as you talk, to see our biases, like, we can think that we have to go there. Right. But actually, what you highlight in the beginning of our talk, this curious, evaluating all the time, like evaluating, not going for something. And if going, so going together, really check that we are in this together, two people.
And I think that's the other thing that they found. So it's very interesting to have other people looking at your tapes and because you have your own view of things, right? But these were 2 independent evaluators, and that is the other thing that they found, is that while they could see that I was definitely following the central dynamic sequence, working both triangles without any question, they said, that I was somehow, warmer, more encouraging, not quite as in your face confrontive as Davenlo could sometimes be. So for them, it was showing, look, this is learnable, it is transferable, other people can do it too, in their own way and be effective. So that was really the point of that book, was to have more of a scientific lens.
Yeah, which is also interesting, because Davenlo himself said that you need, and he wrote about it, that you need to find your own way to do it.
Of course.
Yeah, but you said also there is something about the experience of learning with him, so you need to do it. They're so more focused on the technique.
I didn't find that when I feel like I was very lucky that I kind of trained with him when he was at his best.
Yeah.
So I found him very respectful, collaborative in working together. And yeah, he would show, what was happening and what that revealed about the person's capacity and what was actually required there. But I did not experience him actually as like very dominant or authoritarian or anything. Now it's so interesting because there's always an interaction, right? So some people pull for that, right? So if they come to him in a very passive manner, right, he might in fact take over. So yeah, I had a good experience with him actually. Yeah. And I think often this happened with Freud too. It's the followers who end up idealizing and reifying, right? And sort of almost being more rigid and more Freudian than Freud was, and he said, look, this method I've created, right, free association and so on. He said, it's a pretty good research method. I've been able to figure out how the unconscious works. He said, but it's not a particularly good therapy. I mean, he said that in analysis. He said, now it's up to you. It's up to the next generations to innovate, right? In many cases, they didn't, right? They stuck. So that can happen too.
Yeah,
right?
but you took it, the follower. So you took as also Melon said that you really bring your voice, and encouraging patients and this curious, like you talking to a person, we're talking,
right? Yeah, and we have a conversation.
yeah. And this is very important when you are working in any technique that you are working. So the patient won't feel someone is trying to put that technique on. Yeah. So
right. Yeah. True.
So the partnership. So there was a partnership and other people viewing your work. So it was really interesting and very And so then what was going on then? So then it was 2006, right?
Something around there. Yeah.
How was your work, because you said you are very enthusiastic, but, what things did, you catch along the way or said, okay, I'm putting that aside. What changed in your work, during
if you look at how it's evolved over time. I mean, the thing is, I'm a psychologist, okay, and that's really my identity. And part of the way I was trained in the Boulder model was to be a scientist practitioner. So I read constantly and widely, and I'm abreast of the research across the board. I don't just look at ISTDP or even psychodynamic, right? And what can we learn again about what are the common factors, what are the specific factors, right? Things like that. So I think I just have become more flexible, but also more interested over time in the cases where the method wasn't working the way it should, right? So I got more and more curious about that. And looking at, so in ISTDP, we focus a lot on the patient's defenses and resistances, and nobody's ever talking about, well, what do we create as far as resistance? What do we contribute to that? And why do some therapists seem to always have very high resistant cases and others less so? So I got really interested in that and more of the therapist variables.
So
right?
more
And,
teaching according to that. So
yes,
more, yeah.
right.
Yeah.
And really working with the development of the person, of the therapist. So that really is what that third book was about. I was making the case that it's what you do, yes, you have to know what you're doing, but it's also who you are, and those two being integrated is what's so important. And the other factor that led me to write that book, because again, not just practicing for years and years, but also teaching and supervising, right, and seeing where are things going wrong or what's missing, is I think the way ISTDP is often taught, and certainly the way it's presented, like at conferences, it's all about the big bang, right? It's all about this big breakthrough. And I saw a real neglect of both the critical factors that have to be considered prior to the breakthrough. What do you have to do, right, to set the stage, to create the foundation for that, and also to assess whether is that indicated right now. And then also a real neglect of what to do after. I mean, it's as
working through
the means, right, was confused with the end, as if it's just about getting to feelings. I mean, we've known for 100 years that catharsis is of no lasting value, right? So I really got interested in and wanted to be very explicit about the fact that there are, I think there are 6, right, factors that
so we go to your third book.
that are associated, right, with positive outcome in psychotherapy. And I think the reason that ISTDP is so effective is because it actually incorporates all 6, right? Whereas most therapies only focus on 1 or 2 of those. You know, like let's say AEDP, it's really heavily about the relationship between you and the patient and about empathy, right? And, you know, research shows that that's only, you know, going to attribute about 11% of the variance. So it is necessary, but it's insufficient for change in most cases. So really understanding these multiple factors that are required, right, to help people change in deep and lasting ways. Yeah, so that's what that third book was really.
So there was a passion about helping others to learn it in a way that, you know, they will have more, you know, more tools as they are bringing themselves more as the persons to the room.
Complexity. So, I think it's the danger. What was happening was that the method was getting really reduced, right? It was very reductionistic, like all you have to do is get breakthroughs. And, you know, it's a gross misrepresentation. Things are much more complex than that.
It's a lot of pressure on the therapist also, and really make the process minimize and narrow, like a narrow process.
Right. And I think, you know, that's another, maybe, I don't know if it's an artifact of the way we practice and supervise ISTDP, that because we use videotape, which is invaluable, but it also increases sort of performance anxiety, and people put it, so the focus becomes more on the therapist and less on the patient, right? It's like what the therapist wants to do to prove how powerful they are or something, right? So that can really get in the way. I mean, we're there to serve the patient, right?
Yeah, so we see, of course, that it's very complex.
Yeah.
And we really need to know like have a vision about where we see, you know, have, of course, a conceptualization about every patient, and every patient is different. And, you know, have a vision, but stay, you know, be flexible, work together, and see what we can do together about this problem that the patient is bringing to the room.
Right. And really understanding why you're doing what you're doing. I mean, I think this is the other thing that's missing in many cases. So, since I was trained, I mean, way back when, I would say at least 90% of all therapists in private practice were MDs or PhDs, right? They had very extensive training. They were scholarly, they had, you know, and now the huge majority are master's level. They've had 2 years, right? They don't have the depth. So unless someone is personally motivated, right, to keep reading, and so their why, the deep understanding of human beings, of unconscious functioning, is missing in many cases. They just want to know, what do I do and how do I do it?
That
and
doesn't work. Yeah.
The why. Yeah. And that has to be first, right? Why are you doing what you're doing? How does it make sense, given how you understand this person's problems, and given how you understand what is actually healing, what's therapeutic? And then we can talk about, then you can have whoever said it, right? That when you know your why, there are many hows.
Yeah, it's Nietzsche, I think.
Somebody,
Nietzsche. Yeah.
Right,
it was in Viktor Frankl's book. He quoted Nietzsche, I think. But okay,
Again, when you just have your why and how, you can get very rigid. And then when that doesn't work, you know,
what I do,
you're at a dead end, and you don't have alternative ways, right, to intervene based again on your why. Yeah.
So going to your book that will be come out next month. Hopefully.
These publishers, you never know.
So you said about that, so you really wanted to focus about, okay, what do you do after working through,
Right, there's like nothing written in ISTDP about working through, about termination. It's like everything's about that initial encounter, right? And very rarely do you see the process unfold. I mean, that's something I tend to do. I'll want to show one case, you know, over time so you can see the arc. So again, getting the breakthrough, sort of the breakdown of defenses, breakthrough of feeling is the trigger that opens the unconscious. Well, then you need to be able to understand the unconscious speaking, right? And what does that mean? What do these dreams and memories and associations tell us, right, about the source of the problem? And then what's going to be necessary to help the person resolve, right, that conflict. So in this book on working through, I talk about the concepts of multiple causation, for example. So this is another sort of reductionistic theme that's tended to predominate in ISTDP, the idea that guilt over rage toward loved ones is the one and only cause of psychopathology. Well, obviously, that's absurd on its face, right? I mean, we wish it were so simple. There are multiple factors contributing, right? So we have to discover those, and then also multiple factors in resolving it. So this idea of complexity, and then also tolerating uncertainty, right? Because sometimes I'll have colleagues that never express any uncertainty. They always know exactly what's going on and exactly what they should do next. I'm like, really? How can that be? Right? And again, when we look at the bigger literature, right, on experts and who does best, one of the factors is the ability to tolerate complexity and uncertainty. So you don't want to have this premature certainty about things.
Right.
And you have to be able to tolerate that, you know. So, but it's been shocking to me as I've started to talk to people about this, practitioners who are saying they never heard of the concept of multiple causation. And again, my hair, you know, I mean, this is a psychoanalytic method. How can you do it without understanding, right? So multiple causation, the repetition compulsion, right? What's that about? Understanding that. You know, we talk a lot about building the alliance. Well, what do we do about ruptures to the alliance, right? And how do you repair those, right? Again, what's your role in them? And can you acknowledge that? What else is in there? Also, like how to facilitate a good goodbye, and how the termination, again, has to be very specific to your understanding of this particular person. So there's just a lot of factors other than just the big breakthrough that are required to help people really sustain change, right? Because relapse is a huge problem.
Right. We want to try to do our very, very best, and also our obligation. So when we end, treatment is finished, so we had the best opportunity for the patient really to heal as best as we can.
Right.
Lasting change. Yeah.
Being open and asking them, what they consider, right, the most important factors. Like we have our ideas, right? We're going to tend to want to confirm my own hypotheses, right? But sometimes people will say things like, you're like, really? Like, I didn't think that was such a big deal, but to them, it was huge.
Yeah.
Right? So
you again, curiosity, open mind.
From your patients, about their experience, Yep, so that's the most recent, and I tend to think at this point that will be my last one.
Oh, you never know. You stay curious.
You never do.
There will be another call.
We'll see. I just feel like not the same kind of scholarly. I don't know. We'll see.
Yeah. Stay open. I want to say to you that you bring so much to the field. As you know, of course, it's not the first time that you hear it, but it's so important to say it, that you bring so much. The word that comes up is opportunities and flexibility. And also you can be really tough, but this is very important, so you know your thing, which is very important. You want to learn and you want to go to treatment with someone that knows what you do, but also you're so curious and human, and so present, so it's contagious in a good way.
Oh, that's good. And I hope another thing I hear often is that it's inspiring, right?
All of super inspiring.
I'm not some deity. I mean, some people you look and you say, oh my God, they're so fabulous, and they never seem to make
it's human.
It's I can't do that, right? But when you see me work, you're like, I can do that. Right?
It's so human. And this is what we all want. This is what we are wired for, humanity. So
and I think I am sort of an optimistic person, and so I tend to, when you said opportunities, I look for openings, right? So I'm not just focused on the closed door, right, and all the defenses and resistances. I see that for sure, but then I'll also see the little creak in the door, and I'll say, I see you there. You want to come out, right? So that invitation, right, and really working with what's going right, even if it's small, is also really important, because otherwise, both for yourself and the patient, you'll get very demoralized. If you're just focusing on what's
burnout. Burnout as a therapist, which is very difficult as it is. So we need to keep an eye on our little
absolutely and I also just want to thank you so much, because having students and supervisees like you, right, who are so motivated and curious and open, I mean, it's what keeps me going, right? So, and it's very optimistic for the next generation. So I really appreciate all you do, right, to bring this to your community. So thanks so much.
Thank you so much, Patricia, and we'll see you soon, and good luck in your upcoming book. I'm looking forward to reading it.
Okay. Very good.
Thank you.
Bye-bye.
Bye-bye.